post-Medicare.
Okay, so you would likely transition over to the
Hello?
Hello? Is this working?
I hope so.
Hello?
I don't hear anything.
It is working.
We can
Okay,
hear
good.
you.
All right.
Howdy, folks. Paul Wallace here.
I don't hear anything either.
Yeah.
Yes, ma'am.
Make sure you unmute yourself so you can hear other people or hear yourself talking. Or join with your computer audio on.
Is that better?
I can hear you.
All right. Randy Petrides, can you hear Randy Petrides? And we don't really care if you can hear us, but we want to hear you.
Okay. First.
Okay.
Don't play.
All right, guys, so if you're unmuting yourself, we're going back and muting you so that that background noise isn't there during the presentation.
Can you guys hear us? Can you hear Josh?
Give me a thumbs up for those.
I can hear.
Perfect, you guys can hear. All right. So at the end of the presentation, we'll have an opportunity to ask questions, but let's hold our questions to the end so that we can get through it. For those of you that there's a couple of ways to get in the queue to ask questions. For those of you who are just calling in.
Hello?
Hello?
Hey, Josh, we lost you.
We just lost you again, Josh.
That the second one would be.
Hello?
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 Hello, I can't hear Josh.
Can you hear me now?
I can't hear Josh.
All right, so no one can hear Josh. Can you hear me speaking now?
I can
Yes.
hear you.
Okay.
And can you hear me talking?
I cannot hear. I can hear.
Can you hear me talking?
Yes, I can hear you.
Yes.
Okay.
Perfect.
So what we need is,
We keep losing everybody.
I think we've got a lot of background noise. I'm going to mute lines. If you could please not unmute your line, it will make it easier for everyone to hear.
Are we supposed to have video on?
If you want to.
Okay, other than that, we don't need it on?
As long as you can see the screen, you don't really need it on. We will be sharing our screen today.
Okay.
So Star is going through and muting everybody.
What does that mean for people that are on a telephone? We're not going to see the screen, right?
All of the information that we're presenting today will be available on our website and is actually on the website now.
No, but I don't have a computer, nor do I know how to work one. Nor do
Okay.
I have a cell phone.
So
That's all
where,
right.
Not the only one.
so how do we get on the video, or at least get to the slide deck?
So the slides are available on the website.
Which is what? What's the website?
It is gc4me.com. It is on the Board of Commissioners page on that site, under the VIBA retirement page.
So just let me ask you this, since I am on the telephone, I'm not going to have any paper, I'm not going to have access to any paper or anything then?
Hey, Josh, we lost you again.
Okay, can you hear us? Can you hear us?
Yeah, we can hear you, Star.
Our battery's gonna go dead by the time I get this technology figured out.
All right, can you guys hear me here?
I can hear.
Okay, we're going to try this again for the 15th time. We'll get through it here. So we're trying to mute everybody in the background. Let's save our questions to the end of the presentation so that we can get through the presentation, and then we'll get to your questions. We're going to be here for a couple of hours, and hopefully we can get through all the questions in that time. We did get through all of those questions earlier today. For those of you who are just calling in on the phone, you're not doing the computer Zoom, if you have a question, we ask that you hit *9. That raises your hand to ask that question. For those of you participating with video, if you click on the Participants tab at the bottom of the screen, what that does is open up a white tab over on the side that lists all the participants. At the bottom of that white tab, there is a raise hand option there. So that's what will kind of get us in the queue to ask those questions at the end of the meeting. As I attempted to say earlier, all of the information that Jonathan is going to present today will be available on the website, on the GC4Me under the Board of Commissioners page on our special VIBA page. You know, there may be some questions this afternoon or this evening that we can't answer. We don't want to just blow smoke at you and, you know, just answer to answer. So if there's something that we can't specifically address at this meeting, Maria is going to compile those questions, and we'll have those answers on our website ASAP as soon as we can get those questions answered.
Put this in here.
Am I missing anything? I think that's all I have, so I'm going to turn it over to Jonathan from Plant Moran. He's our part of the team for our consultants that kind of put this plan together for us over the last year. So, Jonathan, go ahead and take it from here, and then we'll get to the point where we can ask some questions at the end. Thanks, guys.
Thanks, Josh. Again, my name is Jonathan Trianfi. I'm a principal at Plant Moran in the Plant Moran Group Benefit Advisors practice. I have a few people on the Zoom call with me today. Ed Murphy, who's the president of our practice, Jordan Richard, and Claudia Hermes. So if you are using the chat feature in Zoom to ask questions, you know, during the presentation, if you see something from one of the three of them, that what they're doing is trying to answer questions while you're listening to me give the presentation. Okay, and with that, I'm going to start the materials, going through the materials, but what I want to do first is let everybody know how we're going to do this. We're really going to break this into two sections, the presentation. The first section is going to focus entirely on pre-Medicare retirees. So those are going to be retirees that haven't yet hit Medicare age or have become eligible for Medicare due to a disability or anything like that. The second half of the presentation is going to focus on Medicare retirees. So just wanted to lay that out so you have a good idea of how we're going to be handling the presentation. I can't share my screen because somebody else is sharing their screen right now. Star, are you able to grant me screen sharing rights or end the one second. If there's a lwyattdo13@gmail.com, I think you're inadvertently sharing your screen with the rest of the presentation here.
Okay, I'll try to stop that. I'll try to get out of that, Jonathan. Let me see. How can I do that?
There should be a button at the bottom of the screen that says share screen or stop sharing screen.
I think I'm in something else. You know, if I just get out because I'm in something else now. If I log out, will that help?
It will.
Okay, so let me, if I can.
All right.
That help? No? Am I
Yes, it
still
did.
shared?
Yep.
Okay.
Yep, we're good now. Thank you. All right. So as I was saying, we're going to start this presentation. We're going to focus on the pre-Medicare retirees. So with respect to the pre-Medicare retirees, just a rough overview of what we're going to go over today. We're going to talk about current benefits, just again, give you a lay of the land, where things are at right now. We're going to summarize the changes, and then we're going to go into more detail. And we've also got an appendix where if we need to, we can show you plan designs and if you have questions relative to the plan designs, how they work, we can go over those as well. So with respect to where things are at right now, all of you as retirees of the county, if you have not reached Medicare yet, you are currently receiving benefits through one of a couple different medical carriers. The first would be Health Alliance Plan. So some of you have Health Alliance Plan, either a PPO or an HMO. Some of you have Blue Cross Blue Shield of Michigan. Actually, a majority of those on the phone that have not reached Medicare age yet likely have Blue Cross Blue Shield of Michigan. And those benefits are either delivered through a PPO or a comprehensive major medical program. And on the screen, you'll see that referred to as a CMM. And then all of you should be getting your prescription drugs through Express Scripts. So the Express Scripts arrangement that the county has covers all pre-Medicare retirees. So what are we doing for January 1st? What's changing? Effective January 1st, 2021, all pre-65 or pre-Medicare retirees will be shifting from your current arrangement, your current medical arrangement with Health Alliance Plan or Blue Cross Blue Shield of Michigan to an arrangement through with Meritain. Meritain is a plan administrator. They are not an insurance company. And what this means is that the county is operating effectively as its own insurance company. And Meritain has been selected as the entity that's going to administer the insurance or administer the benefits for retirees. The Meritain arrangement does include access to doctors and hospitals through Aetna's national PPO network. So that means that the network of docs and hospitals is going to be coast to coast. So it doesn't matter where you reside, you will have access to in-network physicians and hospitals. And if you travel, your benefits will travel with you, and you will have network doctors and hospitals all over the country. In fact, there's an extremely strong overlap in the networks between HAP and Blue Cross with Aetna. In the network that will be used for your benefits starting in 2021, the network has access to all of the hospitals in Michigan. So every hospital in Michigan is in network with Aetna. The other thing is the intent with these changes was to minimize the overall impact or the overall change to the benefits. Now there are some changes to the benefits, but the idea was to try and minimize those changes. And lastly, with respect to the prescription drug arrangement, that will be remaining with Express Scripts. Now there will be some changes with Express Scripts, namely drug formularies. That's the list of covered medications and how they're covered. That gets updated about every 6 months, and there will be an update January 1st. Also, we're going to add some programs that are meant to help people fill high cost medications. So this doesn't impact everybody, but if you are one of those people that have to take a very high cost medication, they're commonly referred to as specialty medications. We're going to be putting in a program so that you can fill those medications at no cost to you. So it'd be a zero copay. Now, again, mind you, these are select drugs, and there's probably only about 1 to 2% of the people on the phone right now that are taking one of these medications. But if you're taking one, you probably know you are. But the idea is to try and get those medications filled with some support from the manufacturers that would end up costing you, again, nothing out of your pocket. So no copays on those scripts. We're also going to be adding some additional support services to the benefits for pre-Medicare retirees. The first is a program through Quantum Health called MyQ Health. It may be a program that you're not familiar with or haven't heard of before. That's okay. The idea behind that program, though, is it is a member advocacy and customer support solution. So this is an entity that's going to work on your behalf to help you navigate what is otherwise a very complex healthcare system. And we'll talk a little bit more in detail about that in a bit. Also, something to note is that, again, for pre-Medicare retirees, when we send out your new ID cards for your benefits, your prescription drug benefits will be included and reported on that ID card. So you won't need to carry a Blue Cross or a HAP card and an Express Scripts card anymore. Okay. All of your prescription drug information will exist on your one single ID card. We're also going to be rolling out a virtual primary care solution called 98.6. So with everything that's going on these days with COVID and especially a few months ago when things were shut down and it was difficult to get in to see the doctor because our offices were closed. The idea behind this solution is we're going to be providing people with access to primary care through a virtual medium, and those services are going to be provided to you at no cost. So you don't have to satisfy a deductible or pay a copay when using that service. We're also going to be including Livongo. Some of you may be familiar with that service right now. In fact, you may be participating in it. Livongo is a diabetes management program, and we'll talk a little bit more in detail about that later. And lastly, we're also rolling out a solution called the KISS card or KISS-X. And what that solution is it's a direct contract or bundled price solution that gives you access to schedulable surgeries or complex imaging like MRIs. It's a voluntary program. If you work through the folks at KISS and have one of those services provided, again, your deductible, your coinsurance, and your copays are all waived. So you can have those services at no cost to you. And we'll talk a little bit, again, we'll talk about that in a little more detail in a bit. All right, so a little bit more detail. Again, effective January 1, 2021, the current medical arrangements with HAP and Blue Cross Blue Shield of Michigan will be ending. Instead, you will be receiving your benefits administered by Meritain. And Meritain will be using the Aetna Choice POS2 Open Access Network. That is a PPO network, like I mentioned before, that has doctors and hospitals coast to coast. If you live in Nevada, you're going to have the same network as somebody that lives in Michigan. Okay, it's truly national network. The other thing to note about this network is that it includes all of the centers of excellence. So if you think of facilities like Johns Hopkins or Cleveland Clinic, Mayo, MD Anderson for cancer diagnoses, all of those facilities are in this national network. In the event that you want to go ahead and search on whether or not your the hospital that you prefer or the doctor that you see is in the network, you can do so on Aetna's website. Okay, that's www.aetna.com. On that website, you can click Find a Doctor, and then you can indicate that you're going to be receiving a plan from an employer, and then you're going to continue your search as a guest. Okay, and the website will prompt you for some other things like, what type of doctor are you searching for? Where are you located? So the geography that you want to search, but that search feature can help you identify whether or not your preferred providers are in network. So speaking to the plan designs, again, are not an exact replica of what you have right now. But as we were designing these plans, the intent was to keep the overall change to a 1 to 3% actuarial value change. That means that what we were trying to do was we were trying to still deliver an overall plan in terms of value that was within 1 to 3% of what you have right now. Based on which benefit that you have right now, you will be mapped and placed into one of 3 different medical plans. And again, the plan that you're going to be placed into is going to be the plan that most closely resembles the total value of the plan that you have right now. Those 3 different plans, those 3 different medical plans actually only have 2 different versions of the prescription drug coverage. So 2 of the plans have the $5 generic copay, $20 preferred brand copay, and $40 non-preferred brand copay. The other plan has prescription drug copays that are $2 for generics and $5 for brands. And we'll get into some more of the detail of those plan designs towards the end of the presentation. Now, something that I want to be very clear about, and this could be different from how things are right now, but there is a situation that we refer to as a split contract. And what a split contract means is that in the case of a couple, one of the spouses is pre-Medicare and one of the spouses is Medicare. Okay. In the event that that were to be the case for you and your covered spouse, or perhaps a covered child, the benefits will be different. Those that are pre-Medicare will receive the benefits that we're talking about right now. Those family members that are on Medicare will receive the benefits that we will talk about in the next half of the presentation. So as part of this change, we also looked at what could the county do to roll out some additions or some changes to the benefits that would actually help people navigate the healthcare system and give people more options to consume healthcare in a way that's both productive for the patient and cost effective for the county as well. So what we're going to be going through over the next handful of slides are what we call point solutions. So point solutions is just a term that we use, a collective term, for all the different ads that we've put into this benefit plan for your benefit. So the first one, again, we mentioned it earlier, is the MyQ Health solution, or through Quantum Health. So Quantum Health is a concierge member advocacy solution. They also do medical management and care coordination. So if there's anything that you remember from this meeting, the thing that you should remember if you're a pre-Medicare retiree is that when you have questions, when you have concerns, when you're not quite sure how your benefits work, you can't quite remember the other details in this presentation about the other point solutions and the benefits available to you, the thing you need to remember is to call Quantum. If you remember that from this presentation, you will be in good shape. Because they are going to be your one-stop shop to help you with anything related to your benefits if you are a pre-Medicare retiree. You will notice that when ID cards come out, the MyQ Health logo will feature prominently on the ID card, and the phone numbers that you will see on your card are actually going to direct you to Quantum. And the folks at Quantum are going to be there to answer all types of different questions that you might have. They're also going to be there to provide clinical support, ideas, recommendations, reminders for you as it relates to how you consume healthcare. So for example, one of the things that they might do is if you're scheduled to have a surgery and your surgeon calls in to certify that your surgery is covered by the plan, Quantum's actually going to take a look to see what the quality metrics of that surgeon are. And if the surgeon is, has poor readmission rates or infection rates, they might call you and give you that information. Again, it's voluntary in terms of what you do with it, but they may also provide you some recommendations on other surgeons that have better outcome measures related to the surgery that you're going to have. Again, what you do with that information is up to you, but in the healthcare system right now, it's very unlikely that you're getting that kind of information if you need a surgery or if you need to go for an MRI or something like that. The other thing is that the folks at Quantum, part of their team are clinicians. So there are nurses that can help you manage your, if you have a chronic medical condition, they can help you manage that. They can provide, health improvement plans and things like that. And last but not least, they're also there to answer all the basic questions. Like if you don't remember what your deductible is, or you don't know if something's going to be covered or not by the plan, you can call them and you can ask for help. This next page, we're not going to go over it in painstaking detail, but it is on the website that you can retrieve this presentation if you want to see more of the information. But the idea here is that Quantum can help you with a number of different things. Okay. So like I said, they can answer just the basic questions. They can put together health improvement plans, but they're also going to be working with your providers. So in the event that a provider calls in, they're going to actually be working to confirm your coverage with the provider and things like that. So the other thing to keep in mind is if Quantum reaches out to you, they're calling to help. They're not calling to interfere. They're just calling to help. So don't put them on a block list on your phone or something like that. When they're calling for a good reason, and it's to make sure you get the best health care and that the outcomes are ideal. So the next solution that we've added to the plan, we mentioned again earlier, is the KISS card or the KISS X card. This is a solution, it's entirely voluntary. You don't have to use this if you don't want to, but this solution is for schedulable procedures. Things like if you need a knee replacement or hip surgery, if you need some form of complex imaging like an MRI or a CAT scan. These are things that aren't emergencies, they're schedulable. If you work with the folks from KISS, they will help you identify a provider that is of high quality, that is located within an acceptable driving range. And in the event that you choose to work with the folks from KISS to identify one of those providers, if you have, then go through with the procedure, all of the services associated with that procedure. So again, if you're having like a surgery, an anesthesiologist, the operating room, the surgeon's fees, everything's going to be bundled together as one service, and you will not pay anything out of your pocket for any of the services associated with that procedure. Folks from KISS will also work and can help with follow-up care if necessary. Now, again, this is something, you know, unless you're already thinking or planning on having one of these surgeries or something next year, this might be something you don't remember about. Keep in mind what I said earlier. If you remember one thing, remember to call Quantum. You don't necessarily need to remember that you have this KISS benefit. All you need to remember is, hey, I think I had something, let me call Quantum and they can remind me of what this benefit is and how I can use it. On this next page, we're showing you some of the locations that where there are KISS providers right now. So you can see that they're scattered kind of across the state. That said, this program is not a typical provider network. So in certain cases, when you need a procedure done, the folks at KISS are actually going to work to identify a doc or a surgeon specific to you. Okay, so it's not necessarily a network like you might think about it now, where you can look up and see where there's in-network doctors and hospitals. In order to identify a provider that participates with this program, you actually need to call KISS and engage with them. The other thing is that this program is not meant to be a PPO network. It's not meant to have providers on every corner. Okay. So in some cases, depending on the procedure that you need to have done, you may need to, if you're living in the Flint area or the Genesee County area, it might require you to drive down to and have that procedure in Southfield or something like that. Or if you're living in, if you're living in the Dallas area and you live in a suburb, it might require you to drive downtown Dallas to have the procedure done. Okay, so it's not necessarily meant to have providers on every corner. But again, the benefit of it is you don't have to pay anything out of pocket for the procedure. The next solution is the virtual medicine or the virtual consultations that we mentioned earlier through 98.6. This is a text-based or text-initiated virtual care program. So the idea is that you can initiate a consult either by downloading the 98.6 app onto a smartphone or going to the website, and you will actually initiate a consult with a doctor via text messaging. Okay. After initiating that consult, if the doctor can't treat you or doesn't know how to diagnose you through an exchange of text messaging, they will initiate a phone call or a video chat, at which point in time the doc can provide you care instructions and can also write prescriptions. The doctors that you will be interacting with are all employed by 98.6. So that means that 98.6 isn't just connecting you with kind of a random physician, somewhere who can treat you. These are all physicians that are employed by 98.6. And the best thing about this is if you need to and want to use the service, again, this is voluntary, you don't have to do it. But if you do use it, the consults are provided to you at no cost. So you don't have to pay a copay, you don't have to pay a deductible. Anytime you want to use that service, it's provided to you at no cost. And this is really meant to be a complement to your normal care. It's not meant as a replacement for a primary care doctor or anything like that. It's more meant to be a replacement for, you know, non-emergent visits to the ER or non-emergent visits to the urgent care. So if you have a sinus infection and you know you have a sinus infection because you get them every year at the same time of year like I do, you know, this, you know, I have trouble getting in to see my doc. So this is a really convenient way for me to talk to a doctor and get, you know, a prescription and antibiotic for my sinus infection, and without having to go to the urgent care or without having to go to the ER, or without having to wait 2 weeks to see or 3 weeks to see my doc. So this next page really just meant to kind of demonstrate how the program works. Again, you're going to initiate the consult via text message. You'll have an exchange with the doctor. And then at the end of the consult, you're going to be given a care plan, a personalized care plan. And the neat thing about that personalized care plan is that it's stored on your account with 98.6. So in the event that you have some follow-up treatment where you have to go back to see your doctor, you can take the care plan and actually send it to your doctor so you know what the doc at 98.6 helped you with and the treatment plan that doc laid out for you. So you've got all that documentation really at your fingertips with a smartphone or just on a website. So the next solution is Livongo. This is a diabetes management program. What this program does is if you choose to enroll, again, a voluntary program, but if you choose to enroll, the folks from Livongo will send you a smart glucose meter and all of your glucose testing supplies. And as you test your glucose levels through the day, in the event that you were to test out of range, so in an unhealthy range, a clinician is going to reach out to you immediately, because the glucose meter will be connected to the internet and will send results back to a clinician. And that clinician will be able to reach out to you immediately to help you get your glucose back in range so that you don't experience a more serious medical issue. In the event that it is in an emergency and the folks from Livongo can't get a hold of you, they will actually reach out to your emergency contacts to make sure somebody is getting in touch with you and making sure that you're okay. So again, the program is voluntary. This next page is really just a little bit of a visual on how the plan works, and the smart glucose meter there on the left in that left circle. But really the value here, not only is getting your testing supplies at no cost to you, but it's really that support. It's really that support service. So if you test out of range, you can talk with a clinician to help you with that without necessarily having to call your doctor or you know, go to the urgent care or things like that. You know, those clinicians are going to be able to help you get your glucose back in range. All right, so plan design. And I know a lot of you, that's probably, you know, if there's concerns, probably where they start. But I wanted to take some time to kind of go over these plan designs. First things first, we had a question from an earlier session about, you know, which of these plans apply to me? On the website, on the county's website, there is a what we would call a mapping document or a planning document that shows if you're in the a Blue Cross Plan A right now, this is the plan that you're going to go to with Meritain for 2021. Okay, so we have people on the phone right now with varying benefit levels, and it would be impossible to tell each of you individually where you're going to go, but that mapping does exist, and it's on the county's website right now. But you will be mapped into only one of 3 plans. Okay. So the first plan, if you look here on the top left of the screen, you will see that the in-network level of benefits for this first plan, the deductible is $100 per person with a family maximum of $200. That means for most major medical services, the first $100 of the cost of those services are your responsibility. Also, there tends to be some confusion around how deductibles work in the event that you have more than one person on your coverage. So if you're covering a spouse or you're covering a family member, every family member actually starts the year with a single deductible. Okay. So even if you had a family of 10, every family member has $100 deductible. So if only one family member gets sick, that family member is only responsible for $100. But at no point in time will a family unit ever pay more than $200 in total deductible expenses. So that could be 2 people in the family incurring $100 of a deductible, or it could be, 5 people incurring $40 of a deductible. But some combination, a family unit will never pay more than $200 in total deductible expenses. The next key plan design feature is the coinsurance maximum. So coinsurance is the portion or percentage of healthcare costs that you pay after you satisfy the deductible. And that's usually applied to major medical services, things like inpatient admissions to the hospital, outpatient surgeries. They're things, that aren't typically routine. At no point in time will any one person pay more than $750 in coinsurance, and at no point in time will any family pay more than $1,500 in coinsurance. So if you looked at a major medical event, let's say you were admitted into the hospital and you had to be there for 3 weeks and it cost $250,000. Okay. That person that was admitted into the hospital, if they were in this plan, would pay $100 for their deductible. They would likely pay $750 in coinsurance, and then they would be done with that hospital admission. Okay. The last number on the top section of this plan design summary is the annual out-of-pocket maximum. Okay. This number is going to look very high, but it's also very deceiving because of the way these insurance plans work. A part of the Affordable Care Act required that all insurance plans, like the one we're looking at here, have an out-of-pocket max that covers both your deductible, your coinsurance payments, and all of your co-pays. Okay. So if we use the example that I was mentioning before, if you're in the hospital for 3 weeks and it costs $250,000, and you paid your $100 deductible and $750 in coinsurance, that's a total of $850, which would apply to this $6,350. Okay, the difference between those two numbers, $6,350 and $850, would all have to be made and paid in $20 increments, which is your primary care office, $150 increments for emergency rooms, or your prescription drug copays. So again, if you're looking at a difference between $6,350 and $850, it's going to be very, very difficult for you ever to have to pay $6,350 because it would be very difficult for you to pay that in co-payments. But this protection does exist if on the very, very, very rare chance that you were seeing a doctor, 3, 4, or 5 times a week for the entire year, this out-of-pocket max would protect you. So if you look at at this first plan, if you use prescription drugs, you would have a $2 copay for generics and $5 for any other type of medication. The second plan is very similar to the first plan. In fact, the only difference between the first plan and the second plan here is the prescription drug copays. So the prescription drug copays in the second plan are $5 for generics, $20 for preferred brands, and $40 for non-preferred brands. Otherwise, all the medical components up here are the exact same as the first plan. And the last plan is a plan that's going to be more applicable for those of you that have the same benefit levels as active employees. So again, that's somewhat dependent on your collective bargaining agreement. But this plan, again, it covers the exact same things as the first two plans. The only difference is the way that the deductible, the amount of the deductible. So the deductible in this plan is $250 per person, up to a family max of 500. And the co-insurance max is the same. But the out-of-pocket max is actually split between medical and prescription drugs. Okay. Again, these amounts are going to be very difficult to ever hit. But in the event that you do, you've got protection so that at some, if you've paid more than, you'll never pay more than $3,600 per person in co-payments for prescription drugs. Okay. But again, that's going to be very difficult to get to $3,600 in $5 increments, $20 increments, or $40 increments. So those are the three plans. The plans are, again, the intent here is to make sure that we're only deviating from your current benefits, the amount of 1 to 3% of total value. And with that, I am going to transition over to the Medicare benefits. Give me a second here. All right. So we're going to switch gears now. So if you are if you have been tuning out because you're a Medicare retiree and everything we just talked about didn't apply to you, now's the time to come back to the presentation, and because this next section is going to be for you. So for all of you on the phone that are Medicare age or enrolled in Medicare, this next section is for you. What you're going to see is that the benefits actually for Medicare folks are, I would say, less complex, maybe more straightforward. So this part of the presentation will actually take less time, but we'll go through the details again. So for those of you on Medicare, where are you at right now? Right now, you're in one of a number of different solutions that the county's offering. You could be, you could have your coverage through HAP, and you could be on a PPO plan or an HMO plan with HAP. You might also be on HAP's Medicare Advantage plan. Okay? There is a Medicare Advantage plan that a couple of handful of people are enrolled in right now. And then a lot of you are likely have coverage through Blue Cross Blue Shield of Michigan, okay? Either through a PPO plan or a comprehensive major medical plan, but you could be receiving your benefits through Blue Cross. And then all of you, except for those of you that are on the HAP Medicare Advantage plan, all of the rest of you are likely getting your prescription drugs through the Employer Group Waiver Program, or EGWIP, through Express Scripts. And so so that is your Medicare Part D benefit. Medicare Part D, you can always remember Medicare Part D is in drugs. So you're getting those benefits through Express Scripts and the Benistar EGWIP relationship that the county has. So where are we going? Where are we going from there? Effective January 1st, 2021, all Medicare retirees are going to shift from their current arrangements on the medical side to an Aetna Medicare Advantage plan. Both the Medicare Advantage plans, and we'll lay them out in a bit, but the Medicare Advantage plans are all have a passive network. What that means, passive network, all that means is that the in-network benefit level and out-of-network benefit levels are the same. So it doesn't matter if you're going to an in-network provider or an out-of-network provider. What you pay when receiving those services are the same. And so what really the only limitation that you have when using that plan is whether the provider participates with Medicare. If a provider participates with Medicare, it's very likely that they're going to accept the Aetna Medicare Advantage plan. And just like the pre-Medicare folks, the intent here was to minimize the changes in benefits. And then the prescription drugs are going to remain with Express Scripts. So if you need to look up a physician or a hospital, you can do that on the Aetna Medicare site. It's aetnamedicare.com. The truth of the matter is it's very unlikely that you're going to need to look up a provider. Because these plans are all structured around the Medicare network, and the Medicare network, again, is federally managed, it's very unlikely that you're going to find many providers that don't participate with Medicare. But if you do need to, you can go to the aetnamedicare.com website. You can click Find a Doctor or Prescription, and then you can indicate that you've got your coverage through an employer or group-sponsored retiree plan. And then when you're prompted, you're going to select that your Medicare Advantage plan is a PPO. Also, just like the pre-Medicare folks, we design these plans so that the difference in your benefits is only about 1 to 3% in total value. Okay, so again, the intent was to keep these plan design changes minimal. So just like the pre-Medicare folks too, you're going to be routed or mapped into one of 3 Aetna plans. Okay, the truth is there's really only 2 Aetna Medicare Advantage plans, but they're matched with different prescription plans. So there's really 2 Medicare Advantage plans and 2 different prescription plans. And you'll see in a bit when we go through the detail how that works. It works very similar to the pre-Medicare folks. Okay? But just like before, we were talking to the pre-Medicare retirees, you're going to have one of 2 different levels of prescription drug copays. You're either going to have a $2 copay, $2 on generics, $5 on brand, or you're going to have prescription drug copays that are $5 for generics, $20 for preferred brands, and $40 for non-preferred brands. To reiterate, because I can't tell you how important this is, because I know it doesn't impact everybody, but if it impacts you, you're likely going to have questions on this. In the event that you're in a family unit where you have both Medicare and pre-Medicare people covered, the pre-Medicare folks are going to get the pre-Medicare benefits and the Medicare people are going to get the Medicare benefits. You won't have the same exact benefits. So now we're going to go through the plan designs. Okay. So we mentioned before there's 3 plans, but two of the plans have the exact same medical benefits. Okay. So the first 2 plans have the exact same medical benefits. There is a $100 deductible, okay, with an out-of-pocket max of $1,100. Okay. That means is that no one person is ever going to have to pay more than $1,100 for medical expenses. So even if you have a catastrophic medical event happen, you will never pay more than $1,100. That includes your deductible, it includes co-insurance payments, it includes prescription, or it includes office visit co-payments. You will never pay more than $1,100 in any calendar year. Okay. You'll see that the office visit co-pays are $20. Emergency room co-pays are $120. And for some of the more expensive procedures, you've got a 10% co-insurance. So that 10% means you pay 10% after you satisfy your deductible. In this first plan, you'll see the prescription drugs, the generics are $5, the brands are $20, the preferred brands are $20, and the non-preferred brands are $40. If you move over to the second plan, you will see that the medical portion is identical to the first plan. The only difference is that the prescription drug copays are $2 for generics and $5 for brands. The third plan is very similar to the first two, except that you've got a $250 deductible and a 20% coinsurance, but your out-of-pocket maximum is the same. So again, the idea there is that in a catastrophic situation, the worst that it's ever going to be in terms of out of your pocket is $1,100. And with that, we are at the end of the prepared materials here. I'm certain that there are lots of questions, and we would be happy to answer them for you.
Thank you, Jonathan, for the presentation. So as we said at the beginning, if you're on just your telephone, *6 to raise your hand, *6 to raise your hand. Or if you're on the video at the bottom, if you click on that participants button, I'm sorry, *9 to raise your hand, *6, it's been a long day, guys, *6 to unmute yourself when it's your turn to talk. If you're on the video or on the actual Zoom call, down at the bottom, if you click on that participants, it'll bring up that white screen on the right, and you can go ahead and click the raise hand button on the bottom. So like I said, we're going to try to keep this to, total call at 2 hours. Somebody needs to be muted. Total call to 2 hours. We're about an hour in on the presentation this morning. It was almost perfect. I think we went over by about 3 or 4 minutes. So we've got some folks here that have questions, and we'll go to the first one, Diana Rutherford. Diana Rutherford. Good evening.
Hi. I have a question about, my situation would be that we would have two separate plans. And how does a family deductible work if I have two separate plans?
Yeah, so if you have two separate plans, the folks that are on the pre-Medicare plan, so I guess a question, is it just you and a spouse, or are there other people that are covered?
I have a daughter that would be on the separate plan, and my spouse and I on the Medicare plan.
Okay, so your child would have their own single deductible with the pre-Medicare plan, and you and your spouse would each have individual deductibles with the Medicare plan. Okay, so there would be no family deductible for your child. She would have a single deductible on the pre-Medicare plan.
So she would have the $100 deductible.
Correct. Yep. If that's the plan that you map to, yes, she would have a $100 deductible. Yep. Not the family deductible.
As far as these, can I ask a second question?
Mm-hmm.
Sure.
I have a whole page of questions, but I won't take up everybody's time. I'm a little all these plans are substantially the same as my current insurance because they don't appear to be, especially in cost. Out of pocket seems to be more than 3%. You're saying 1 to 3%. They out of pocket cost appear to be more than 3%. So I think that's a fallacy that it's 1 to 3%. So I'm a little confused on why we're selling it as 1 to 3% when you start adding these things up and it's substantially higher.
Yeah. So the truth is that right now many of the county's plans don't have out-of-pocket maximums at all. Okay, they're grandfather plans so that you would continue to pay out-of-pocket. There's no cap on them. Okay, so while some of these look like they are a significant benefit curtailment, the truth is actually by adding these out-of-pocket maximums, we're actually adding protection that doesn't exist on the current plans. Okay. So that's why cosmetically it may look like a curtailment, but in actuality, the application of the benefit really is only a 1 to 3% change versus what you have right now.
So when I'm paying more per doctor visit, I am paying more per physical therapy visit, I am paying more per prescription, and I'm now paying, I would be paying or lab work and that kind of thing, 10%. I'm not sure how that can be a 1 to 3%. It's not. It's astronomical. And I don't have a ton of prescriptions, but I'm amazed by the number of people that do, and concerned that this is going to put people in a very unfortunate situation where they're going to have to choose between their medication and the affordability. And I'm concerned, I guess my other question is, when you were computing all of these numbers, was there any computation that took into account those kinds of things, meaning that people were not going to be able to afford these doctor's visits or medication, and therefore would be sick and die, and then the county wouldn't have to pay?
No, the calculations that we went through are actuarial calculations. So what we do is we take a look at the plan design in total, as it exists right now, and as it was designed going forward. We said, what is the actuarial value difference between those two plans? Okay, and there isn't much in the way of actuarial value difference between the plans as they exist right now and the plans as they've been designed for 2021 and beyond.
I don't think that's accurate, but okay.
Okay.
I won't take up any more time right now.
Thank you. Our next person in line here is David Mack. David Mack. You'll want to unmute yourself and you can.
I'm on my husband's computer, so I'm Judy Mack. And right now I pay hardly anything. I mean, my out of pocket is zero every time I go anywhere. I pay maybe a couple bucks every so often. But I agree with Diana that I've never I'm not sick a lot, nor have to have a lot of stuff done. So I will be paying more out of pocket on it whenever I have to have anything done. So I guess I totally agree with what she's saying. But my other question is, the plans, you're mapping us into what you want to map us into as far as the 3 different plans?
It's not based on where we want to map you. It's based on what you have currently. So you're being mapped into the plan that is closest to the one that you have right now.
Okay. But again, I think that we will be paying more out of pocket.
Yeah, I don't think we're arguing that you could pay more out of pocket. I think what we're saying is that the total difference between the plan that as they exist right now and the plan that you will be moved to is no more than a 1 to 3% actuarial value difference. Okay.
But you keep saying actuarial, that's going to be for a catastrophic accident or surgery or something that I'm not in that category. So unless you're in that, yes, I can see it if you're in a catastrophic issue.
Yeah.
But if you're not,
yeah. So
that's what you mean by when you say actuarially?
Yeah, and it's because it's all based on averages. But the way that insurance works in general is, well, we all hope that we're in the category where we don't have a lot of medical expenses. If we knew what our medical expenses were going to be for the future, we wouldn't need insurance. So while you might not be in that category this year, you may be in the category next year or 5 years from now. And that's really the intent of insurance, is that when you are that person that needs the insurance the most, you're not being impacted to the same degree as, a 20 or 30% change. Okay. So that's when we say actuarial value, that's what we're talking about. We're talking about the people like you that are in relatively good health and don't need a lot of care. And we're talking about the people that are the opposite that need a lot of care.
Thank you.
Mm-hmm.
Should ask that question.
All right, looks like next on our list is Susie Temple. Susie Temple.
Hi, good evening. Jonathan, thank you for the presentation. The question I have is, I am pre-Medicare and I retired with the benefits that the current employees have. So my question is, I understand all the plans that you've laid out. I understand that I'm in the Plan 3 or Plan C for the pre-Medicare. So I understand that part. But my question is, I'm in the defined benefit plan. And so I get a monthly pension check from the county with a deduction for my health care that I pay monthly for a family plan. So what's the cost of that? Does that part go up as well, or does it? I'm unsure about that cost.
So I can speak to it a little bit. Susie, right?
Yes, I'm
Was
sorry.
that your
Who's
name, Susie?
talking?
Okay.
Yes.
This is Josh Freeman.
Josh, thank
So
you.
the board took, yep, not a problem. The board took action maybe 2 meetings ago to eliminate any premium costs for the next year to be reevaluated at each budget for any retiree, current retiree that's paying a monthly premium. So your premium for next year will be eliminated.
So you said it's going to be readdressed after that year. Are there?
Right. So, yeah. So what part of the process is when they go through the budget each year, they're going to look at what those overall costs are, and the intent is to try to keep that premium cost gone for the future, but they'll review it at each budget year. So they've guaranteed or they've promised to do it at least through the next year, and then in the fall next year they'll reevaluate as part of the budget.
Do you anticipate at all that it go past what we're currently paying?
So you are one of the retirees that mirror actives, is that what you said?
That's correct.
Okay, so I can only speak from my own experience as an active, and since I have been here, that cost does fluctuate. So to say that we can tell you what that cost would be, so let's say we get through the budget this time and the cost is such that the board wants to reinstate that premium for those retirees that are, I want to say eligible, but that, are required to pay that premium. I can't tell you that that cost will be greater or less than what it is this year, because it's really based on claims from year to year. Does that make sense?
Yes, I do. I understand. But so what you're saying is it'll never increase or never be more than what the current actives are paying.
History here at the county has shown that retirees do not pay more than the actives pay. So I don't anticipate it, but I can't, I don't have a crystal ball that I can say what's going to happen by a board 5 years from now. I don't know why they would do that, but I'm not going to promise you that it'll never happen because I can't make that promise to you.
Thank you for the information. I understand. Thank you.
Yep. Thank you for the question. Looks like our next person that wants to talk is Shelley Spivak. Shelley?
Yes, do you hear me?
We can.
Okay. My question is, right now I recently retired and went on Medicare at the same time. So right now I'm paying a certain amount to Medicare each month for Plan B, and I'm paying a certain amount to the county. So what who will I be paying? Will I be just paying Medicare in the future as of January 1st? Will I still be paying that Plan B?
Right. The charge from Medicare is by Medicare, not by the county. So yes, you would continue the Medicare charge. The county charge is what you will be getting relief from. Okay. And are the benefits, for example, does it include anything like hearing aids, the benefits?
Jonathan can speak to that. It does include coverage for hearing aids.
It does?
It does. Yep.
Do you know how much and how often, or?
So it is, the plan is going to cover
$2,000 every.
Yeah, $2,000 every 36 months.
Okay. That's my question. Thank you very much for your time. I appreciate it.
Yep. Thank you, Shelley. Next caller is Lisa. Lisa from Scranton? No, I'm just kidding.
Hey, I just wanted to ask you if when we change over to Aetna in January, will that cover all of our pre-existing conditions, or will we have to worry about what they will cover and what they won't?
Yeah, Lisa, thank you for asking that question. We probably should have brought it up during the presentation, so thanks again for asking. There will be no application of any type of pre-existing conditions, meaning your coverage can't be limited because you have a pre-existing condition. So as you move, and this goes for both those of you that are pre-Medicare and those of you that are Medicare. Regardless of the current medical conditions that you might be dealing with, you cannot be denied care or denied coverage because of that pre-existing condition. So if you're dealing with a medical condition right now, you will receive the benefits as if you didn't have that medical condition, if that makes sense. Okay, so there's nothing that's going to prevent you from getting the full range of benefits on these on both the Medicare plans and the pre-Medicare plans.
Okay, so yes, all pre-existing conditions are covered.
You got it.
Okay, thank you.
Thank you. Next caller, the 410-6440. 410-6440, you'd need to hit *6 to unmute. There you go.
Okay. My name is Shirley Byrne. And I
Hello, Shirley.
retired in 1991. And my contract, of course, like you've heard over and over again, my contract says that the county will provide me with lifetime coverage. So this is quite a shock to me. Right now I have a $50 deductible and $2 prescription. That's it, and that's all I really have to pay for right now. I guess my question is vision is covered, right?
There are no changes to vision or dental.
So will we get a new vision card
No,
and a new dental card?
no.
No, I don't believe, Anita from our HR is here. She can speak to that for you.
So our vision and dental coverage is through different providers. It's not through the medical. Your vision, you should have an NVA card, and your dental is through Delta. Those are not changing in this process.
Okay.
If you don't have those cards, you can contact HR and we'll order new ones for you.
Okay. I do have cards. That's why I wondered if it was the same or not.
Yep, those will stay the same. It'll only be your Blue Cross or your HAP card that you will no longer need.
Delta dental card.
Correct.
And vision is NVA.
Correct.
Correct.
Yes.
Yep.
Okay. I did run across, I was checking doctors today, and I was quite surprised that, of course, McLaren Hospital covered, but my family physician is McLaren in out in Davison. They said no, they're not taking Aetna.
I
think Jonathan can speak to that for you.
Yeah, are you a Medicare retiree or a pre-Medicare retiree?
I'm a Medicare.
Okay. So if they accept Medicare, it's very likely that they will take the Aetna Medicare Advantage plan. If they say they're not taking Aetna, they may not be taking a specific Aetna network. So really what you should be asking is if they accept Medicare. And if your physician accepts Medicare, they will very, very likely take the Medicare Advantage plan through Aetna.
Okay, well, I'll check with them again because I know they take my Medicare card and my Blue Cross Blue Shield card.
Yeah. And in that case, it's like I said, it's extremely likely that they are going to take the Medicare Advantage because they're going to be, that provider is going to be reimbursed based on Medicare. And that's typically what they're concerned about.
Okay.
Thank you, Shirley.
Thank you very much.
Yep.
Okay.
Our next speaker is Chet Coop. Chet, are you out there? You'll have to unmute yourself, Chet. Chet, as you work to get that figured out, we'll come back to you. Teresa Rundell, are you out there?
Yes.
Hello, Teresa.
So when I go to the doctor, when I'm sick, I'm just confused on what my copay is. Like if I go in because I got a sinus infection, usually my copay's been $15.
And Teresa, what are you pre-Medicare or Medicare?
Pre-Medicare. I
Okay.
retired under the old plan. So I wasn't paying anything into healthcare monthly.
So Teresa, your copay going forward would be $20 for an office visit. So that the copay, if you're paying 15 right now, it would go to 20.
Okay. So do I have to pay anything in as far as a monthly insurance, or am I still don't have to pay anything in?
Now, if you had no premium previously, you have no premium now.
Okay, so I'm confused about the whole deductible thing.
Yeah, so those terms, it's like insurance companies deliberately try to confuse you so that you can't figure out what the heck's going on, right? So you've got an annual deductible. Think of that as your car insurance. You get in a car accident and you have to pay a deductible towards any type of repair that you have. And then once you've met that deductible, then you're responsible for what we're calling a co-insurance, or what they call a co-insurance, up to a maximum amount. So for some people, that's $1,000 a year for the Medicare Advantage plans. For others, it's, I think, $750 a year per person, and then there's a maximum for a family. And so once you've hit your deductible, you've hit your co-insurance maximum out of pocket, then you're just responsible for your doctor's visits, like a copay. And we've got I think, a helpful guide on our website, on our VIBA page, that kind of explains what those terms are and kind of walks you through it. I'm going to give out my direct dial number here at the county, 810-762-7762. And, you know, if you have a question that maybe we aren't able to get to here tonight, or you want to go deeper in depth on something, feel free to reach out to me at that number, and I will get back to you, or I will give you to HR, who may be able to answer it a little better. But we can walk you through what those terms mean, Teresa.
Okay, because I was just wondering, you know, when I go to the doctor, I'll just be paying $20 instead of $15 if the doctor accepts my insurance.
Mm-hmm.
Right.
Correct.
Yep. All right. Thank you. Looks like, Chet, are you on the line there? Were you able to get it figured out? There you are. Go ahead, Chet.
Yeah, I had three questions. I'm a retiree, post 65, so I'm on Medicare. And I just have two questions about deductible co-insurance maximum.
Mm-hmm.
You were saying during the presentation, you were explaining what these maximums were, and you misspoke, I think, or I wanted to check if this is what you meant. Are those maximums, like co-insurance and deductibles, is that per person or is that per institution? Because you said institution at one point.
It's per individual.
Okay. All right.
Yep.
All right.
Yeah. So if it's you and a spouse, you each have your own $100 deductible, or $200, depending on which plan you have, either $100 or $250 deductible, and you each have your own $1,100, out of pocket maximum.
Okay. And does that maximum out-of-pocket apply to prescription, or do you pay the co every time?
You pay the copay every time on prescriptions.
Okay. And then my last question has to do with when you were talking about the pre-65s, you were talking about access through virtual, the 98.6 and
Yep.
all these other different things. What those obviously aren't available, I'm understanding, to us. And so who do you contact, and do you get those, do they offer the same type of thing through Aetna?
Yeah, so there is virtual options through the Aetna Medicare Advantage plan. These things, the reason that we can't provide the same or aren't providing the same exact services for the Medicare folks is there's more regulations on Medicare because it's a federal program. But especially with what's going on with COVID, there's been a lot of leniency in the Medicare space about providing virtual care. So you will get virtual care through the Aetna Medicare Advantage plan.
Okay. Just one, and I don't know, maybe there's not time to do that. Maybe experience will tell. A lot of times these services that are offered, when you call them, you have to go through a long phone tree, and then they ask you for a number for this and a number for that. And so my question would be, is this accessing program tree that you have, is it something complicated like that? Do they coordinate the information, or every time you call back, you got to give them the same information about why you're calling? Is there some coordination of this data that you provide?
Yeah. So I'm going to say it's going to be better than you might think it is, but I'm not going to claim it's going to be perfect. We work with Aetna and their Medicare Advantage solution with other clients of ours. And the general feedback that we get is they're good. Nobody says they're excellent, but we're told they're good. Not every situation is gonna, from a customer service standpoint, is gonna turn out fantastically. But I think you'll probably be pleasantly surprised in terms of how they're able to help you.
Okay. All right. Thank you much.
Yep.
Thank you, Chet. Looks like our next caller is 989-743-4386. You'll have to hit *6 to unmute yourself. 989-743-4386. Are you out there? No? All right, we're going to move on to 241-9538. 241-9538. Are you out there? *6 to unmute yourself. *6 to unmute yourself. No? All right, we'll go back to David Mack.
Do you have to have a referral from your physician to go to a specialist?
No.
So it's the same as Blue Cross Blue Shield, you can go where you want to go.
Correct. Self-referrals.
And Mary has a question here. Go ahead, you say it. Okay.
What if our doctor, we find out, does not accept the Aetna, and we don't want to change doctors? Can we still go to our doctor, use our Medicare card, and pay the balance?
What you would have to do in that case is you would have to pay for the service and then request reimbursement from Aetna. Okay.
And
So
if we know our doctor doesn't accept it, we know they're not going to reimburse us. Okay, but we can, in other words, we can still use our Medicare if they refuse to take Aetna, and we don't want to change doctors again.
correct. Yes.
But that situation, Jonathan, can you talk again about that?
Yeah.
Situation is highly unlikely that your doctor, if they accept Medicare, would not accept the Aetna Advantage plan.
Yeah.
Well, they do take Medicare, and she did say that the girl talked to there, that they do have people coming in with an Aetna Medicare card, and they take that, but I don't know if it's the Advantage Plus, but it probably is.
It is.
Okay,
It definitely. Yeah. Yeah. I'm fairly confident that it is.
Yep.
Yeah.
Okay, I appreciate that. Thank you.
Thank you. Maria, you're next. Unmute yourself, Maria. Maria, there you go. Perfect.
Okay, I've
Yes.
got a question on Medicare. If you don't want to go to the Medicare Advantage Aetna plan, can you just keep your Medicare and then maybe take a secondary insurance, or do I have to go to that?
So this option, the Medicare Advantage option, is the only one that would be presented to you through the county. But the county can't compel you to take the benefit. You're always within your rights to not accept it. And if you wanted to go out and find your own insurance, that's your prerogative. Obviously, if you were to go out and find your own insurance, though, the cost associated with that insurance would be your responsibility.
Okay, all right, thank you.
All right, next caller, 287-7394. *6 will unmute you. Are you there? Yep, go ahead.
I am. Okay, we have several questions, maybe some clarification on a couple things. You were speaking, we are Medicare recipients. So, and you had discussed with a few person before that there will be no deductible for next year for the lady that had a deductible. What about people who have never had a deductible? Obviously we're not going to have it next year, but is there a possibility that the deductible is coming to us after that?
So it's not a deductible. It's a premium.
A premium
Right.
is what I'm.
Right, a monthly or a yearly premium. At this point, there is no intention to implement a premium for those who did not previously have one.
Okay.
There's not even been any discussion of that, so I don't want to just make it sound like, that they're planning for something down the road. There's been zero discussion about if you had no premium previously, that there would be at some point in the future a premium.
Okay. And then you discussed several times about if a doctor took Medicare any place in the United States, that you should be able to get in with the few exceptions that you've talked about there. What about hospitals? And I'm thinking specifically out of state. If they accept you as a Medicare person, then is Aetna going to be okay in those hospitals?
Yes, the same concept would apply to hospitals. If the hospital is accepting payment from Medicare, they will very likely take you as a patient with a Medicare Advantage plan. In fact, hospitals are where you're going to experience probably the least amount of issue. Typically at the doctor's office, sometimes they're just not familiar and you just have to talk to the right person. Most of the hospitals, their billing departments are so well-staffed and very on top of things. You're likely to get very little pushback from the hospitals.
Okay. Now, also, you were talking about with one lady about the deductible being $20, possibly $20. Is that, however, after you've paid your first 100 or 250 or whatever?
Yeah. So
like the first time I go to a doctor in January, am I going to get a $20 bill, or am I going to have to pay my full deductible first?
You will have to, if in the Medicare plan, you will have to pay your full deductible. Okay.
Okay.
But once you meet that deductible will have been satisfied for future office visits and future hospital stays. Okay. So it is truly one deductible.
All right. And then I have two more quick questions, hopefully. Is that okay?
Yeah, go ahead.
All right. One is, you talked about hearing aids, glasses, dental. What about medical equipment, at-home health care, those kinds of things?
Yeah. So medical equipment is referred to typically as durable medical equipment. Durable medical equipment is covered by all of the Medicare Advantage plans, all the different varieties that we showed you today. The plans also cover skilled nursing and at-home care. Okay, so those services are covered.
Okay. And then my last question is, if someone opted not to take this at this point, but down the road wanted to, are they able to get back into this plan?
Yeah, so through the annual open enrollment period, you have the ability to opt in.
Okay, I think that's it.
Thank you for your
very
questions.
much. Thank you very much for your help.
Yep, not a problem. Next caller is 275-2147. 275-2147, *6 will unmute you. There you go.
Hey, it's Paul Wallace.
Oh boy, Paul Wallace, what's going on?
Well, I got three basic questions. And the first one has to deal with, this looks a whole lot like an HMO or a PPO, and I've had some really bad experiences with that, as in I'm sick, I need to go to a specialist, but I have to get a reference from my doctor. My doctor is reluctant. Is that where we're going with all this? Right now, Blue Cross, I can just go to a doctor, any doctor I want. Is that going to change?
No, it will not change. And Paul, are you a pre-Medicare or Medicare?
Yes, I'm pre-Medicare, but that's going to change here in a couple of years. And then I'll be a split person because my wife will be pre-Medicare and I will be Medicare. And then we'll, if I survive, we'll transition to full Medicare.
Well, I'm pulling for you, Paul.
Thank you.
But the answer in both cases is these plans are self-referral plans, meaning you don't have to go to your PCP to go to a specialist. If you want to self-refer and you want to circumvent the PCP and go right to the specialist, you can choose to do that.
Okay.
I would tell you that, if you've got a good relationship with a PCP, my recommendation is you try and steer as much care through your primary care doc as possible, because typically that's doc that's going to know you the best, and is going to also give you the best recommendations in terms of where to go. Otherwise, my recommendation is if you're going to go see a specialist and you're going to circumvent your PCP, I would call Quantum and ask them for a referral, because they've got quality metrics that they can give you. And they're gonna have information that the average person doesn't have with respect to the quality of a doctor.
Okay, let me just say this. I was in EMS around here for a long time. I know a lot of doctors, and I don't, that's a throwaway for me. Okay, you answered that question. Thank you. Next question is, and this may be a Josh question, who do I call downtown to review all this? I'm going to need somebody to walk me through it. And I know we've had some changes in the benefits office, and I don't know who's in that chair right now.
So
Josh,
Paul, yeah, you can call me directly. You've got my contact information.
Sure.
Or you can call HR, and we can have the benefits person, who is Diana now, in our benefits department, and she can help you as well, whichever you're comfortable with.
And for everybody on the line today, there's more information coming. This isn't the last meeting or chance you'll have. We're going to have Aetna. We're going to have meetings with them in November. You'll be receiving notices for those Medicare retirees. And then the pre-65 retirees, we're going to have Meritain. And we're going to have meetings with them just like we are here today. This is just the first step. So there'll be more information coming, more chances for you to ask questions.
Okay, cool. Thanks, Anita. And one more thing, overseas travel. That's something nobody's touched on. We go out of the country frequently enough, and what about that? I get banged up over in, let's just say, France.
Beirut.
Yeah, Beirut. Well, those are my friends. I'm not going there. But I do have friends over there, but never mind. What about that overseas travel?
Yep. Yeah, Paul. So if you're overseas and there's an emergency, you've got coverage. So these plans, none of them cover kind of routine care. So like if you just wanted to go see a doctor or something when you're overseas, but if you had an emergency situation, like let's say your appendix burst or something, these plans,
Thanks, man.
yeah, I like to dole it out. But you would have, these plans would cover that. Now I don't want to gloss over anything or make it sound like it's simple, but when you're overseas and you receive medical care, those providers don't integrate with our insurance system. So a lot of times what happens is you as the patient have an obligation of reporting some of that information over to the insurance company in order to get reimbursed or in order for them to facilitate payment on those, those services.
Yeah, that's not really a change, actually. That's, you kind of got to do that now. I got Blue Cross Master Medical, and it's a dance, but I just want to know if, all right. I've got a whole bunch of other stuff, but I can follow up with HR, and so I'll step out. Thank you.
Thanks, Paul.
Thank you, Paul. Appreciate the questions. 908-1433. Have we tried that number yet? *6 908-1433.
No, that's me. My name's Mary Seymour.
Hi, Mary.
How are you?
Good, thank you.
My husband and I will be Medicare. I am Medicare and he is not, but his birthday is January 3. So I'm assuming that's going to be no transition problem for 2 days.
Medicare actually takes effect on the first of the month of your 65th birthday. So he will actually transition to the Medicare Advantage plan straight from January 1st.
Okay. And the other thing is, you mentioned this quantum. Does the Medicare people have a number or a facility like that to call that answers all those questions?
Yeah, that's going to be Aetna for you, for the Medicare Advantage folks. So you would be calling Aetna to get any questions answered with respect to your medical insurance.
Okay. And when we got our coverage last April, we chose the HAP, and it was the most inexpensive one, like $43 a month. And so the mapping that you're talking about that you do is based on, for us, it was just because we're basically healthy people, so we picked the cheapest one thinking we would never need it. So is that something that I'm stuck with, or does that change? Is there an option to change if I needed to?
Jonathan, I can probably answer that for Mary.
Go
hey,
for
Mary,
it.
it's Anita from HR.
Hi, Anita.
Hi. The 3 plan choices that you had during open enrollment all mirror, the plan design was all the same for all 3 plans. They just had different costs associated with them. So the fact that you chose one plan over another plan didn't change where you mapped to in the new plans.
Okay. All right, another question. This is my last question. When I use my healthcare for any reason, say I go to the chiropractor and I get adjustments, I give them my Medicare card and I give them my HAP card, and my Medicare says, well, we're going to apply this much to your deductible. So does that same amount for my chiropractor visit also come off of my deductible for the Aetna at the same time, or do I have to do both?
No, the Aetna Medicare Advantage plan integrates basic Medicare, okay? So first of all, as of January 1, when you get your Aetna card, you can put your Medicare card away in a safe spot. Don't get rid of it. Please don't get rid of it. Put it away in a safe spot. You will only need to carry your Medicare Advantage card and your prescription drug card. You will no longer need to present your Medicare card when you're receiving services. And when you do receive the services, the deductible that we showed you in the presentation today, that is the deductible both for that would otherwise be applied by base Medicare and your supplemental coverage. So it's all rolled into one.
Oh, okay.
So you only have one deductible, and it's the deductible that we showed you today.
Okay. All
Thank
right,
you for those
you.
questions. All right, looks like our next caller, 629-5548. 629-5548. *6 will unmute you. 629-5548, no question?
Oh,
Oh, there we go.
There you go.
yep, I'm Pat Mossman.
Hi, Pat.
And, hi. I do not have an Express Script card. Do I just call and get one?
Yep, you can call HR, and they will get you a card and get you taken care of.
Okay, unless I've got it in another wallet somewhere, I don't know. And then on the letter they sent me, it says you will no longer have to pay the Medicare Part A and Part B deductibles. So is there some kind of money that I'm going to not have to pay out?
Not that I'm aware of.
No, the letter, it's Anita from HR again. The letter
Yeah.
that you received is kind of what Jonathan just described. It's one deductible. So you're still going to pay to carry your Part B insurance. But the deductible that Medicare applied as part of the Advantage plan, it's one deductible. So we didn't want you to think that you had two.
Okay, so it's just one. Okay. Yep. And then the other question, sorry, that I have, like, if you, I didn't quite understand. If you go to the hospital, say, and I'm a retired Medicare, if I go to the hospital and the bill would be like $5,000, I would have to pay the first, I forgot what you said, like $750, and then the insurance is going to pay the rest of it? Or I have to make $20 payments until it's paid?
No. So if you went to the hospital, so as a Medicare participant, if you went to the hospital, let's just say it's on January 2nd. So you haven't satisfied your deductible or anything. So you go to the hospital, it's $5,000. You're going to pay $100 towards your deductible. So that's the first 100. And then you're going to pay 10%. Okay. So of the $5,000, you pay the first 100 as your deductible. There's $4,900 left. You'd pay 10% of that, which is $490. So you've paid a total of $590 for that hospital stay. And that $590 would be applied to your out-of-pocket max. So $590 would come off of your out-of-pocket max for the year in that case, at which point in time, if I'm doing the head math right, you'd have, $510 left of your out-of-pocket max?
Oh, because it's $1,000 deductible.
It's $100 deductible and $1,000 out-of-pocket max. Okay.
Max. After that 1,000, then I don't pay anything.
You got it. So yeah.
Oh, okay. That's what I wanted to know.
Yep.
Okay, I think that was the only question. You guys are really wonderful and very patient. Thank you.
Yep, thank you.
All right.
Next caller, so we're running up about 15 minutes left, folks. Next caller is Barbara McCowan. Did I say that right? Barbara?
Yes, can you hear me?
We can, thank you.
Okay, yes, McCowan. Yes, what my question is, the letter said that they would have additional benefits on the new plan. So my question is Silver Sneakers or any exercise program included?
It is not included.
That was my question. Thank you.
Okay. Thank you, Barbara. Next caller is Verizon Wireless USA's iPhone. Mr. Wireless or Mrs. Wireless, are you out there? You have to unmute yourself. No?
I'll take it because I have an iPhone and I'm a Verizon Wireless. I don't know.
I don't think you're that person though. Next one is.
Wait, Josh.
No.
They just unmuted themselves.
Okay, go ahead.
Okay. Can you hear me? It must.
Yep.
Okay, it must have been me then. I'm sorry. My name is Ronald
That's all
Higgerson. I'm retired from the prosecutor's office. I have just several quick questions. I think the last The next to the last lady asked the question I was going to ask about the 10%, if that was included in the maximum out-of-pocket for the Medicare patients.
It is.
She answered that because on our printout, it says not applicable for the co-insurance maximum. And I wasn't sure if that was included.
Yeah. Because there isn't a separate co-insurance maximum. The idea there is in that $1,100 annual out-of-pocket max, that's your deductible. It's any co-insurance amounts that you pay, but it's also any co-pays that you pay. So if you paid a $20 copay for a doctor's office visit, that's going to buy down your annual out-of-pocket maximum by $20.
Yes. Okay. Well, I think that was the big question I had was that. Okay.
Great.
Thank you. Thank you.
You're welcome.
Thank you. D. Wilkes, are you out there?
I'm here. Can you hear me?
We can. Go ahead.
Okay. Jonathan, you mentioned one thing, and I kind of want to go back to this, but let's say I go to the doctor and, hey, it's 2020, and she tells me I need a lobotomy. Maybe something not quite as serious, maybe hip, knee, or shoulder.
Yeah, let's do that.
Okay. But let's say she recommends a surgeon. And are you saying it's first you said maybe, your doctor knows you best and, go with them. They know you best, whatever.
Mm-hmm.
But then with this Quantum and this KissX stuff, what's the advantage? You said it's voluntary, but would we stop, go home, call them and say, hey, is this doctor in your program? And then at that point, do they take over? Do they schedule the surgery? And what kind of delay are we talking about? Is it the same as working with your doctor? My doctor would normally call the surgeon and say, we want to get this patient in. If I call Quantum, is Quantum pull that kind of weight that your doctor does? And is it going to be, okay, I can get you in 2 weeks?
Yep. Yeah. So first of all, the engagement with Quantum is voluntary. Okay. The other thing is they're going to reach out, and in some cases, they're going to reach out to you. So you wouldn't need to come home and reach out to them unless you wanted to. But in some cases, they will reach out to you to notify you or make sure that you understand what's associated with the procedure that you're going to get. If you need any help in scheduling the follow-up care, that type of thing. But the program, the KISS program, they may present to you as an option to say, this is an option to you. If you choose to use it, there's no out-of-pocket costs associated with it. Again, it's voluntary. You don't have to use it.
How do they even know that? You said they may reach out to me. How do they even know what's going on between me and my doctor?
Fantastic question. So if you were ever to be scheduled for a surgery, and this happens right now, you may not even know it happens, but it does right now. Your doctor's office or the surgeon's office is going to call the insurance to go through what's called a pre-certification process. That's where the doctor's going to make sure, or the surgeon's going to make sure, one, that you're still covered by the insurance, because they want to make sure they're going to get paid for the procedure, and they're going to tell the insurance company why that procedure is necessary. So they're going to make a medical case for appropriateness.
Okay.
So when the doctor calls now, usually Blue Cross or somebody's going to take that phone call. They're going to do the intake, and that's the end of it. You never see it. You never hear it. You don't know what happened. All you know is that the surgeon followed through with the scheduled surgery. Going forward with Quantum, instead of just taking that information in and approving the surgery, they're going to take the next step to reach out to you and say, hey, we see that you were scheduled for a knee surgery. We wanted to make sure that you remembered that you have this benefit through the KISS program and knee surgeries are included. Would you like to consider using that service? You can say no, and that's the end of it. Or you could say, tell me a little bit more, and they'll help you. That's how they know. There's stuff that goes on behind the scenes in the insurance world that usually is kind of like a black hole. It never goes anywhere. Quantum's model is to engage both provider and patient in a way that we're trying to steer people and remind people of the benefits that they have available to them so you can be a good consumer of healthcare.
Okay, thank you.
Mm-hmm.
Thank you. Next caller, 989-666, 1639. Star 6 will unmute you for the call.
All right, you got me?
We got you. Go ahead.
All right, now I got half right now, and I go from June to June. Is my deductible going to change now from June to January now on the first of the year?
Yeah, it will start, the deductibles now will reset January of every year. That also is consistent with Medicare. So the Medicare Advantage plans have to reset in January because that's a requirement under Medicare. So the decision was made to keep the pre-Medicare retirees consistent with the Medicare retirees, so that there isn't a change when you cross from, the pre-Medicare benefit to the Medicare benefit.
All right, thank you.
You're welcome. Thank you for the question. Diana Rutherford, you're next. Looks like we've got about, just before Diana, 1, 2, 3, 4, 5, 6, 7-ish callers that still want to get a question in. So just ask that you're mindful of the time.
Okay. I just want to
Thank
get
you.
a clarification on using my daughter as an example. Currently, we have the Blue Cross, which means she's paying $15 for an office call. When she goes in for diagnostic testing, x-rays, and MRI, there is no co-insurance payment, and generally everything is covered. So in this new plan, she would be paying $20 for an office call, and she's going to pay 10% for any diagnostic test, x-ray, MRI, lab work, radiation therapy. Am I correct?
You are correct.
You're correct.
That could be a substantial amount of money. Can we agree on that?
It'll be, what is the deductible for it, and what is the out-of-pocket max?
The deductible is $100 per person.
Yep.
The co-insurance maximum is $750.
So it'll be $850 a year.
Compared to what now? Right now, it's nothing.
Right.
So that's substantial to me.
Yes.
Not be substantial to you, but it's substantial to me. It's
No, it's
not
substantial to me.
It's not 1 to 3%. That's my point. And I feel like this is being sold as 1 to 3%, and it's not. It's a substantial increase.
Right. I think Jonathan tried to explain that we're looking more globally at the plan when we're talking about the 1 to 3%.
Is it a 1 to 3% savings for the county?
1 to 3% savings for the county. No, it's not.
I'm saying 1 to 3% consideration as far as the county's concerned, and not the retirees.
Right. So I think what the plan was for the commissioners was that as they looked at what the cost of health care for retirees was going to be in, say, 5 years, 6 years, 7 years, that number of $35 million was not sustainable over the long term. I understand that any change to retiree health care is substantial for anybody. I get that 100%, that it is a substantial change. But when you need to look at the ability to continue providing a benefit to the current 1,200 retirees and their families, and to be able to do that as promised over the life of those retirees, that something had to change in order to make sure that the dollars were there to provide that benefit.
Well, I think that there was some poor planning on the part of.
Oh, 100%.
Absolutely. And so now
Yep.
basically the retirees are paying for the poor planning by the commissioners and the folks that essentially rated the VEBA fund.
So rating the VEBA fund is probably a different discussion, because I don't think there was any rating of the VEBA fund. But yes, over time, I think that sometimes previous boards did not take into consideration, I'm going back from when these contracts were approved, right? Did not take into consideration the county's ability to pay for that for the life of the, the retirees there. So yes, and I don't think that anybody on the current board would argue with you that that was a problem.
There's another thing to keep in mind too. This is just a broader issue in terms of planning and things like that. There is a lot of people that didn't think that healthcare costs could continue to increase at 8, 9, 10, 12% a year. That at some point in time, those increases would have to kind of flatten out. That hasn't happened. So the pace that healthcare costs are increasing, and some of that, by the way, is related to the type of care that is covered. So, I used the hepatitis C. Hepatitis C 10 years ago couldn't be cured. Now it can be cured with a $60,000 medication. So the medical world changes in such a way that costs are still increasing at a very significant rate. And that just wasn't expected. You can call it poor planning. You could also call it great medical technology and advancements in what we're able to now treat that we weren't able to treat yesterday. It's going to happen again. We're going to have the COVID vaccine, right? None of us really know how much that's going to cost, but we're probably all going to need it. So there's that type of thing contributes to kind of the dynamic that we have right now with healthcare costs. So it's just, again, I don't want to explain it away. I just want to give you some perspective on, the other side in terms of what's going on in the medical world.
I understand, and I don't want to be angry with you, Jonathan, because it's not your fault, and I think you're doing an excellent job at explaining all of this. I just think it is substantial for a lot of people, and I feel bad for the people that this is going to impact horrifically. But I guess they vote, so we can take care of it there.
All right, next caller is Marcy's iPhone. Marcy's iPhone. Go ahead, Marcy's iPhone.
My wife's a retiree at Genesee County, and I noticed when you were listing the KISS providers for no cost, MRI, CAT scans, PET scans, stuff like that, that there's nothing in Genesee County. Are there plans to provide that service at no cost for the Genesee County area residents? And for example, when I go to Cleveland Clinic, they are very specific and they want to do their own MRI or CAT scan because I have an aortic aneurysm, and they measure it each year to see if it's changed. It sounds like my now out-of-pocket expense for that is going to be 10% of the cost of the hospital bill, up to $1,000 because I'm post-Medicare. That 10%, is that of the gross charge, or is it a net charge that Blue Cross Blue Shield agrees on a reduced price for the hospital service? For example, it may be $10,000, but the hospital agrees to accept $3,000. So where does that 10% apply to? The $3,000 or the $10,000?
The 10% would apply to the $3,000. Remember, in the post Medicare space, the reimbursement levels are typically negotiated by Medicare. Okay, so that 10% is what Medicare has approved for that procedure. Okay, so it's just like what the discounted amount would be. Okay, but right now, if you have Blue Cross, typically Blue Cross isn't the one negotiating that price point. They're actually leveraging the price points that Medicare has negotiated.
Okay, what about the KISS this year?
Yeah.
There's
Yes.
nothing in Genesee County.
Yeah, that is the intent there is to develop the network closer or within the Genesee County borders. Right now, there aren't providers that participate, but again, these procedures when somebody uses the KISS program, the folks at KISS may be reaching out, and that agreement may only be for you. So it may not be for, may not be a network agreement. It actually may be what's called a single case agreement, where they've negotiated a price point specific for your procedure at that surgery center with that surgeon, and it's a price for you and for nobody else. Okay. Over time, that can change where providers actually join the KISS program broadly. But the folks from KISS will actually work to negotiate that price point with a provider closer to home. We just can't list them because it's going to be a one-off situation.
Will there be a
Okay.
advocate advantage to do that with Cleveland Clinic?
Cleveland Clinic is very unlikely to participate. They don't need to participate in that because they're a center of excellence, they're a specialty center. So it's very unlikely that they would participate.
So it will be a
All right.
of 1,000.
Mm-hmm.
Okay.
Correct.
Thank you.
Cross
Go
Blue
ahead with your
Shield-
last question, please.
Did Blue Cross Blue Shield match the insurance plan costs from Aetna for the retiree insurance costs? Did they agree to provide the same service for the same price?
They did, but they made it contingent upon the county agreeing to give the entire population to for both actives and retirees. And the county could not promise the active population at January 1st. So it was a contingency that the county could not satisfy in order to take advantage of the proposal from Blue Cross.
Okay. Thank you for that last question. We've come up on our time limit of 8 p.m. We do have another call tomorrow at 2 o'clock. So if you want to be on that call, you can go ahead and email us at theviba@co.genesee.mi.us. And I'll give you all my direct dial number. Again, it's 810-762-7762. That's my direct dial phone number. I've gotten a few calls today that I've got to return, and I'll probably get a few calls tomorrow. So just bear with me, but I'll get back with each of you. Just a reminder again that the presentation that Jonathan did will be on the county's website, that VIBA retirement page, along with a link to this video, so you can watch this video again if you want to later tonight or tomorrow morning or next weekend if it's raining. There's also a link to the video this morning if you want to watch that one. And like I said, we do have one more of these presentations with Plant Moran tomorrow at 2 o'clock. Anita mentioned earlier that Aetna will also be rolling out a presentation for folks in November, so you'll get notice of that as well. So I want to thank everybody for being here tonight. I think we had up to about 115-ish people here at one time tonight. We're down to 73 now, had 100 and some earlier this morning. I expect the same tomorrow. So thank you all for being here. I hope you guys have a good night, and we'll see you if you're interested tomorrow. Thank you.
Thank you, everybody.
Thank you, Josh. Thank you, Jonathan.
Thank you.
Bye-bye.